Hey, what's happening, everyone? Good evening. My name is JB White. Thank you for joining me. So good to see you tonight. I'm a general dentist in Las Vegas, and tonight I only have an hour, so I want to jump right in. So I have three case studies for you tonight. I got Mila, Jeff, and Elaine. They're all going to be different, and they're all going to be utilizing a whole armamentarium of digital tools. Okay. So we have our cone beam, we have our intraoral scanner, we have our facial scanner, so we can get hard tissue, teeth, and soft tissue. We're going to be printing, we're going to be milling. And if you've been with me in a course before, you know that I love photos and videos. So you're going to see a lot of that tonight as well. Okay. You all have a chat box too, by the way. So if you have any questions at the end of tonight's program, I'll open that and I'll address all of those. So please, as we go through, feel free to ask as many questions as you like, and then I'll stick around as long as I can. Okay. So here's Mila. Mila is a dentist herself, and she comes in and she, about a couple of years ago, about 3 years prior for me meeting her for the first time where I shot these images, she had some composite bonding done. And so she had 6 through 11, some veneers bonded with composite. And you can see she's chipped and fractured almost the entire left side off. And she's not sure what she wants to do. She does mention, hey, maybe it's just time for some porcelain. And I said, well, let's take a look and we'll figure it out. So here's her right side. And you can see she's had a little bit of staining. And the left side, she's fractured the canine off initially. And then once her guidance was gone, she took out the central. She's had previous ortho. She's completely healthy. She doesn't like that she's a little more bulky on her right side. And so we want to address that in the grand scheme of things. So here's what we have. We have some previously done composites. She really liked them when they were originally done. She also mentioned that she has this orthodontic bar, and you can see that it's fractured here at the midline. And so she says, can you remove this and make me a removable retainer? I'm tired of dealing with it. So I said, no problem. We can incorporate that into your plan. And so I start always by evaluating kind of tooth position relative to the face. And so when we look at her lip at rest position, you'll notice where she hasn't fractured off the composite is about the display we want to see for, a 32 to 35-year-old. So, a 30-year-old on average showing 3.3 millimeters. And then where she's fractured the tooth off here, back down to her original enamel, you get an idea for just how much tooth structure she's worn away. And so here's her full face, lip at rest, and her full smile. And if we start to kind of evaluate things in terms of leveling her inner pupillary line, and then also, then I like to put a line perpendicular to that and kind of see where we are in the middle of her face. And then whenever I'm dealing with the anterior teeth, if I have the opportunity, I like to shoot a little video. It gives me an idea for how the lips move. And I like to share this with the ceramist and the CAD designer who's going to be working up the case. And so we look at things, and I like to ask all of you, what's our plan? What would you do? Here's Mila, 34-year-old female dentist, and what's our plan? And so I actually want her, like all patients, I show them their images. We have a conversation style treatment planning session, and I kind of ask them. And she kind of says, well, what would you do? And I said, Mila, I think your teeth are beautiful, and I don't want to prep them. And so what we decided to do is we're going to bleach, we're going to remove the lingual bar, we're going to make her a new retainer, and we're going to do 6 composite veneers. But Mila is kind of specific in the fact that she doesn't want to go without anything on. So she won't let me remove it all, let her bleach, and then come back. And so I need to get all of the records where she is, and then I'm going to do it all in one day. Okay. And so we're going to start with our intraoral scanning. We're going to make her models, get them into the digital world, treatment plan them in exocad here. And this is what we're thinking. We're going to lengthen that right central a little bit more, mirror image the left, lengthen the laterals, and the canines also. Remove a little bit of the bulk on that right side. And the other thing is we need to really work out her function. So we're going to give her a little more volume to the teeth facially. But what we also know is if we don't want the same fate to happen to our composites that she's had, previously, we need to make sure that we get the excursions worked out so that she's riding up on new composite and she's on the canine and off the central. And then when she goes from, right and left lateral excursions up to her anterior teeth, that everything is nice and smooth. And so you can see that in our digital design, we're already planning on adding some composite to the lingual of the canines and also the central. So when she goes into protrusive movement, on both sides here. And then what the advantage to composite in this situation is I don't just get what I get back from the lab. I have the ability to kind of over bulk it and then fine tune it and even add additional, the day of if I need to work out things and just kind of balance forces however we want. And so here's our final design from the anterior and then these lateral shots so you can kind of see everything. And then what we're going to do in Mila's case is we're going to import her photos into Exocad and kind of design the smile, being that we're just working on the front six, in her face so that we can see the midline. We can kind of visualize what it looks like. And here's a quick video of kind of the process of Edwin, my ceramist, working up the case, where she started, the whole process, and just a nice, quick, easy, fast digital workflow. Then, once we get the design done, we're going to print it. So we'll print, we'll wash, we'll cure using our shining system here. And here's Mila's design brought back to the analog world, okay? So we print the model, and then from the model, I'm going to mix up some putty. I like to do this myself. I don't let the lab do it because I don't want to make a matrix that is, like if we were doing full crowns or full veneers. I don't want it to wrap. I want to mix the putty and I want to wrap just the incisal edge just barely. So I'm going to use this matrix from this whole design. It's the only thing that I'm going to use, but I'm going to use it just to build the lingual shelf and the incisal edge just where it starts to turn out, kind of moving towards the facial. So the palatal shell is all I'm going for with the matrix. So here's her right side. I'm trying to capture all the embrasures, and then I'll trim it a little bit on her palate so I can have a nice, easy seat in her mouth. So now I'm going to bring Mila in. We're going to have her bleach every day for 2 weeks. Then we're going to have her wait 21 days so she doesn't have any bleach remnants in her enamel, which we know will affect the bond strength of our composites to her teeth. And I'm going to bring her in, and I'm going to very carefully remove all the composite. Now, remember, she's been bleaching. I've never actually, until this point, known entirely what's under the composite. I've never seen her teeth. And so I need to be careful removing the composite. It's a tedious task. And I'm going to be doing the bonding today. So I need to make sure that I don't nick her gingiva in any way so that I create any sort of bleeding that's going to cause me a problem, with the bonding of these composite veneers. Okay. So now for the first time, with everything removed, I can see what was hitting. Was composite hitting in excursions? Was a tooth structure? And now I'll have her kind of go through right lateral. And then you can see right here that if I don't build something on this canine, she's going to pass and she's going to hit the composite on the central coming from the lingual, and she's likely to shear it off. Here she is in protrusion. You can see she's fallen off the canine here. And then when she goes into left lateral, same thing. If I don't build this up and start it on the lingual and have a nice smooth transition, she's going to take out the composite here on the left central. So I check all of these movements. It's coming with our guide. And this gives you an idea of exactly how much length we're going to add to everything. And then I like to get my color palette down. And so before I've done too much and the teeth have had, a chance to dehydrate, I like to start putting some composites on, curing them to see if there's any color change when they do in fact cure, evaluating them, and then telling the team, okay, here's going to be the different resins that we're going to use on this particular day. And the only thing that I'm going to do to her teeth is I'm going to aerabrate them to remove the aprismatic enamel layer. I'm going to etch and I'm going to bond. That's it. So absolutely no bevel, no prep. That was kind of her wish, and it's my wish also. And then individually, I'm going to add the composite, the lingual shelf, to the matrix, seat it into place, have my assistant cure, and that's going to be my starting point and how much I'm going to lengthen her teeth. I'll come in with a blade and I'll remove this little flange right from the get-go. And then I'll come in and I will add all of the colors and all of the layering that I want, one tooth at a time. And then I won't completely finish it, but I will partially finish each one individually and then come over and do the next central. Then I'll do the lateral on the right side and the canine on the right side, and then the lateral on the left and the lateral and the canine on the left. And then I like to start taking images to help me see things clear as I'm adjusting length, opening incisal embrasures, finishing lines, having her smile. And I also like to get the patient up, sitting in front of me and coming in with discs to kind of get everything worked out, and then laying them back in the chair to kind of do the final, polishing, contouring, and finishing of the composites. And so at this point, I've gotten everything on. I can start really dialing things in, putting our secondary and tertiary anatomy in, evaluating things from the right and the left. And let me show you a video of how Mila ended with a very feminine, short lateral, curved, rounded distal edge, some nice translucency to the, lower 1/3 of the incisal edge of the centrals. And then let me show you everything in her face. So I put her back in the studio and I just hit record. I have the camera sitting on a tripod and I ask her questions, and I want to get her laughing and smiling, and I want to kind of see the dynamics of her lips entirely. And then remember, I did not touch her teeth other than aerabrate and etching. So here's a video of kind of before and after to remind you of where she started. And here was her teeth once the composite was removed, and here was her design, and then her final result. So a very conservative plan, bonding, layering composite, and something that's very easy to maintain. If she ever were to chip one, I can come in and repair it. All right. So that's Mila and our first case. All right, let's move on to Jeff. So Jeff comes in, and his wife and daughter have kind of encouraged him to do something with his teeth. And you'll see that he has very good home care. He just has a lot of good wear and tear. He has some abfraction lesions. He has an anterior end-to-end occlusion. He has a lot of posterior wear. He's had a lot of secondary eruption as a result of the wear, and his teeth are getting, rather short, and he's completely symptom-free. He doesn't have any caries, but you'll notice that I do have a lack of overjet. And so if we want to get some function and we want to get some overbite, I got to get room to do that. And so we have to kind of discuss what our plan of attack is going to be. You can see the composites that he has up here at the gum line. You can see that he's chipping away. He's had some bonding here on the right central. And he wants to look good. He wants things to function. And he wants to have as few problems moving forward as possible. Here are his occlusal views. He's had very little dentistry on his maxillary arch. He's had crowns on his second molars, and then the first and second molars restored on his lower arch. But other than that, a couple of composites here and there, and mainly just some tooth position and a lot of wear and tear. You can really appreciate the wear here and kind of the dentin windows shining through on everything from his second bite to his second bite in both arches. Okay, so let's move him into the digital universe. And the first thing that we're going to do is some ortho. And really the key to Jeff's case is setting everything up properly. And so before I show you what my plan was, I'd like you to just look at this and ask yourself, what would you do orthodontically? And so my plan is to get the soft tissue in the ideal position. So I need to get him in an ideal canine relationship and then intrude his teeth significantly, especially on his upper left, so that when I prep, I'm not prepping a prep tooth. Okay. And so watch this movement over here and appreciate how much intrusion we're going to do. We're going to do some IPR on his lower left and swing everything around. If you're unfamiliar with this software, these triangles you see here, these squares, are the interproximal reduction. And then the green that you see here is going to be the residual space after the movement. And then everything is being planned to kind of get papilla and facial gingival margin position ideal. And so the intrusion down here on the lower, on the facial of these, you'll appreciate that we're making no effort whatsoever to align his incisal edges. And so we will do that with the restorations. We're trying to get overjet so we can build an overbite, and we're trying to get his gingiva in the ideal position so that once the teeth are restored, that we have teeth that are the exact same length. Okay. And, he's already prepped some of the teeth for us. And so we have the before over here on this side of your screen, and then the after over here. And we're going to do a total of 1.5 millimeters of IPR on that lower left to swing things around. So that's kind of where we're going to get some of the room. The rest of the room is going to come with expansion of the maxillary arch. And so again, the before on this side of your screen, after the orthodontic, here's our treatment plan. And we will see how much of this we're able to get. And then we're trying to get the facial gingival margins on the upper right in the ideal position with intrusion. Same thing on the lower left. And this is our ideal plan if we can get the space. And then you can see that the restorations will be almost entirely additive to go in. So we won't be prepping a prep. If we prep these teeth on Jeff, we wouldn't have very much left at all to bond to. Certainly no enamel on the occlusal surface. If we can get the intrusion, we may not have to, we may not even hit the tooth to get the clearance that we need. Okay. And then here's his anterior relationship. So we're going from this situation where we have absolutely no overjet to this where we can lengthen both his mandibular and maxillary anterior teeth. So we'll fast forward here to the end of ortho, and Jeff was so compliant. He wore them 23/7. He only took out his aligners to eat, brush, and floss. And other than that, he was probably the most compliant orthodontic patient I've ever had. He did an absolute fantastic job, and there was not a single refinement done in his case. So you can see this is him in occlusion, and maybe he's protruding a little bit forward too, but you can see the space that we were able to get. You can see the intrusion we were able to get down here on his mandibular anterior, and then also creating some space over here. So at the end of ortho, everything is opened up exactly like we planned. The expansion is done fantastic. Everything is looking good. And now we're going to introduce another tool. And so we want to get his soft tissue into the mix. So remember, on Mila earlier, we put her photo, which is okay when you're working on just a couple of anterior teeth. But when we're working on a full mouth, we want to have an avatar that we can use and that the technician can see to completely diagnose the case. And instead of it being a two-dimensional image that we're building three-dimensionally on, we can make something, and I know this looks like a Hall of Fame bust at the moment, but it gives the technician so much information. And you can see this is Jeff on the right side of your screen, where his tooth position was before. And then we can put his avatar into exocad or 3Shape to really be able to see the buccal corridors, how things look in terms of tooth length and width from the right and the left. And it just helps us get a better final result. And so here are his models with the initial design. Here's his lowers. And then we can go through and we can move our sliders in exocad, and you can get a visual of where his tooth position is after ortho relative to where we're going with the reconstruction. And you can see if we come in and, we do our incisal depth cuts, we're not even going to get to his teeth. We intruded everything. And so the porcelain thickness on almost his entire mandibular arch and his maxillary arch, for that matter, is going to be almost all additive. And so I'll show you the preps in a minute, and I'll show you how kind of we control all of that when we get to the chair. So here's Jeff's design. Once we get the design done, same thing, print, wash, cure. And now we have Jeff's models. So unlike Mila, where we made just a little incisal wrap, we're going to make full arch, very thick putty matrices of this new digital design. We scheduled Jeff. I like to do this maxillary arch day 1, mandibular arch day 2, have them back a week later for occlusal analysis. I interview them in terms of their final indications of exactly what they want, how they want the incisal embrasures, what they want the laterals to look like, final color, gingival blend, translucency, pericomata, all the different things, facial anatomy that they may want. We want to get that dialed in. Okay. So I bring him in day of the maxillary arch prep, and I will go ahead and spot etch and transfer the mock-up right over his existing teeth. And so we did not, everything in his case, because of the ortho being so ideal, was additive. Now, sometimes we might have a tooth when we're doing preps that's sticking out, let's say facially, and I'll show you that on our next case. If that's the case, one huge advantage to doing all this digitally is that we can print what we refer to as a 2-in-1 model. So we can say, here's our final position, and we can print that model, but then we can print a model that has their window of tooth sticking out to the facial or wherever it is, so that we can still bond this up, and then it helps us prep. We can just polish back whatever tooth is sticking out. Then we're left with this, and then we can make our depth cuts. That's something that's really, really aided us in terms of, instead of just sending in models and saying wax up ideal, we only ever got back one matrices when we in fact did that. Okay. So we bond it all in. We can evaluate the smile line. We can evaluate the aesthetics. We can have him start talking and evaluate his speech and his phonetics. And then here's where he started, by the way, just as a reminder. Then I will get out a leaf gauge and I will have him slide forward, back, and squeeze, and I can ensure that we do not have any interferences. And so we took centric relation bite records with the scan, and so we did upper lower scan, and then I use a leaf gauge to have him slide forward, back, and squeeze, making sure no teeth are touching, and then I'll scan the relationship of the upper and lower teeth. So everything has been designed in centric relation, and I can confirm that now, walking him down to one length, one leaf, and then making sure nothing touches, removing that one length, and he's absolutely perfect. Or if there's any problem, I can polish it and eliminate it and equilibrate him. And now I've worked out the aesthetics and the function of the entire case before I've even started on anything. So it's a very safe, relaxing way to know where I'm going. And now if I prep the maxillary arch today and then provisionalize him just like this and he leaves, he's already got an ideal occlusion coming back the following day to do the exact same thing on his lower arch. And so it's a very comfortable, controlled way to kind of go through the reconstruction. So day one, here's our preparations. And so the only crowns that he's going to get in the maxillary arch are going to be where he had the crowns. And so it's his second molars. And so we removed crowns here. We clean up any existing buildup material. We redo all the buildups. We're going to pack 2 or 3 cords on every single tooth so we can get a beautiful scan. You can see here on the facials where we had all of that abfraction and the bonding. I remove all of that. I redo it. I make sure that we have a nice path, and everything is going to be an onlay. And if you look closely, you can see that we can even still see some of the pits and fissures on these premolars, and he still has some enamel on the occlusal surfaces because we did so much intrusion. And then I bond in the mock-up and then make the depth cut into the occlusion of the mock-up. I don't even remove very much of his tooth whatsoever. And then on everything here on the first molar and the first and second premolar, a burr is never taken to the enamel on the axial wall of the lingual. And so it's just the occlusal reduction that we need, a conservative facial reduction, which might require a little bit more depending on the degree of the abfraction lesions. And then I break contact very conservatively. I want to keep those, I want to break contact, but I want to keep the margins interproximally as coronal as absolutely possible. And then on the anterior, I'm going to wrap the porcelain around the lingual because I want full control of the function. If I don't take the porcelain on the lingual of the maxillaries, what I am, I'm stuck not having control of the incisal edge of the mandibular anteriors. And so I want that in the ideal position of his face. But if I've opened his vertical, the way that I control that is by wrapping some porcelain down. And it's going to be a very conservative prep because when we open the vertical, I don't need room for restorative material. I just need to put the restorative material there so that I have control over the forces and so that I can get coupling of anterior teeth. And so that's the rationale for everything that was prepped in the maxillary arch. And then in the mandibular arch, it's the exact same thing. The only crowns that he got were the crowns that I cut off. Very conservative onlay preps on the premolars, and then veneers canine to canine. So conservative reconstruction, leaving as much enamel as we possibly can. Every single restoration in his mouth will be bonded in. And so one of the things that you and I always need to have clear in our mind is if he were to ever have any restorations done at his current pathological occlusion, we're prepping a prep tooth, which is exactly what happened to all 4 of those molars. And so his axial wall height is very short. And so even though I have full coverage restorations, all of them have to be bonded because they're so short because they were prepping worn teeth to begin with. So intervening early, like we did with Mila earlier, and evaluating and really recognizing what is happening can really help us set these patients up for long-term success. Okay. So here's Jeff a couple days after I've prepped him. He comes back. We start to evaluate things, look at color, look at length, all of those decisions that we would want him to make. Here he is compared to his initial presentation way back when. And so we can get some feedback from him. We can take some headshots. We can evaluate things. We can put that interpupillary line because you and I are always going to tilt the camera. or he's going to tilt his head. So I put that line on the screen. I rotate his photo. I put a 90-degree photo to that, or excuse me, line to that on his photo on the screen, evaluate the midline, make sure nothing is canted, and I provide all of this information back to the technician. And Edwin did such a great job of designing the case from the get-go that we loved it. He loved it. His family loved it. We didn't really want to change much of anything. And so we photographed him. We will come in with the intraoral scanner. We will give the technician a copy of the provisionals so that we have intraoral scans of everything all the way along. And then we go to the lab. Every one of Jeff's restorations are going to be designed and they're going to be milled. We pick the color that we want. We mill them all out. And then we're in an era where I never thought I would see this in my career, but, you know, I have in the lab back behind me here, I'm still at the office today. I have every articulator and every face bow. You know, SAM3 is my favorite. We have lots of others because lots of other dentists prefer other ones. They send them in. But today we are customizing condyles and flosses with other software and printing out custom articulators that work better than anything I've ever had in the past. We can build custom guide tables here, write in and print those off. We can design these a number of different ways in the software when we print them. Here's his vertical. And then the days of ditching dies are also behind us. And so I've been a lab owner for, I don't know, about 5 years now. And, you know, we were always pouring up models and ditching dies. Today, we 3D print the dies. We can check margins and evaluate everything by just printing them out. Mill the restorations. So it's, you know, it's mill, it's print, and then it's putting together the puzzle on everything that we have fabricated to get to the final result. And here's Jeff. So then in one day, I bring him back in, I remove all the provisionals, and all 28 restorations are bonded in from coming in the morning and finishing up about, you know, 2:30 in the afternoon. And then I have Jeff back in. Here he is about a week and a half post-delivery, and his initial presentation on the left, and his final restorations on the right. And the smile is one thing, but check him out in the after. You know, he looks great. He's taken 6 strokes off his golf game. He's up for anything. Okay. So case study, start to finish, digital workflow, printing, milling, facial scanning, fixed reconstruction. All right. Our final case of the evening, and the case that I'm most excited to share with all of you. So here's Elaine. Elaine gets referred in from her physician, and she has discomfort on her upper left anterior teeth 9 and 10. And when she occludes, she has class 3 mobility on those teeth. And so she knows she has to do something, and she'd like to avoid a denture, is what she and her husband tell me on that initial visit. Okay. So we get all of our records, we document her lip at rest. And so you'll notice that when we look at this, she's not showing anything. And so we will set that probe on her incisal edge. We then relax her lip, and you'll notice she's about -2. And you'll also notice when she was smiling, she wasn't showing a lot of tooth. So we know we want to lengthen her teeth. And at this point in time, she would like to keep her mandibular arch. And so she has a ton of plaque and calculus buildup, as you can see. And you can see and just imagine the mobility that she has here when she bites and the discomfort she's having. She still has some stops over here on the right, but on this left side, and she's kind of posturing forward because that's the only way she can get her teeth to touch. And so we don't have a ton of inner occlusal space in the back. So we're going to open her vertical and work up her ideal tooth position. So here's the maxillary arch. Here's her pano derived from the cone beam. So she has these remaining 7 teeth and severe bone loss on 9 and 10, a very large defect, as you can see here, and moderate localized to generalized bone loss on the upper left. And so we are going to treat her maxillary arch at this period of time. So here's her scan, and you can see also, and this is going to come into play, just how proclined she is on these anteriors here. And so we're going to start collecting everything as we've somewhat shown. We're going to get Elaine's soft tissue. We're going to do our intraoral scan and get her teeth, and we're going to take our cone beam and get her bone. So we have bone, we have teeth, and we have soft tissue. And I want to share some screen recordings of this whole process. And so the aoral scan elite on the left side of your screen, the Medi Smile on the right. And we do a number of different facial scans. We average 3: full smile, bigger smile, and retracted. So the retractor's going in. You can see I'm standing off to her left side, kind of coaching her, making sure she's standing in the right position and getting everything together. So then we need to now correlate that information. So we'll do that in the Shining software. And so we're going to take her cone beam. Watch this. We're going to overlay that and superimpose that in. And so now we have her full avatar. We have her bone structure, we have her soft tissue, and we have her teeth. Very important to stress, this is Elaine. It's not a cartoon. It's not some guesstimate. It is her. And so we have now everything that we need to plan her case. We have where her soft tissue is, we have where her teeth is, and we also have her bone structure. Once we get all that, our first step in this whole workflow is going to be design. So I'm going to send the case back to Edwin, just as I did the previous 2, and he's going to design where we want her final teeth to be relative to where her current teeth are. Now, remember I told you about that 2-in-1 model. Her teeth are so proclined that you can see them protruding through the facials of our final design. So her current teeth are the green ones. Where we want her final teeth are the blue. Then we work out her occlusion. We determine how much we're going to open her vertical. And here's our final digital design. Here it is, overlaid with some transparency to her current tooth position. You can see how we're coming out the facial. You can see how we're pulling everything back. We're closing the spaces and we're opening her vertical. Now, we're going to nest and print. And this is our 2-in-1 model. We're going to print everything. So here's her current position. Here's the 2-in-1. Now, this is a model that we also love even for veneer preparations, because if we were veneering these teeth, we would polish off her teeth. Then we would have what we want for our final result. So we could transfer this right into her mouth, prep her teeth off in the facial, do the depth cuts into our final tooth position, going. So remember, tooth prep is always dictated based on where you are versus where you want your end result. And so that's not the case here with Elaine. We're obviously going to be extracting all these teeth, but I just want you to grasp the concept. But in her case, what we are going to do is we're going to make a putty matrix of the final design with her teeth over the top. I'm going to lubricate her existing model, and I'm going to use that matrix right over the model that you see on the upper left to make us some occlusal stents. Because when we scan the case, I want to scan the occlusion with the final result in mind, not just her current occlusion. So everyone wants to talk efficiency in terms of the digital workflow. I'm going to show you what we've come up with and what's working really well for us at this period of time. And so here's our jig, and then we will hand articulate her mandibular model into that, and we will make this bite registration. Now, I want you to remember that bite registration, because now we're set up occlusally to move forward with her case. Okay, remember that. We'll come back to it. So here's our occlusal vertical jig. And now we want to plan out Elaine's implant position. And so this is just a sped up version. This is Real Guide software. I'm partnering with Implant Concierge to do all of this. They're my absolute favorites in guided surgery. They're a wonderful company to work with if you're looking for a partner in that. I didn't do guided surgery, honestly, for the longest time because I thought it would just slow me down. I now know that once you have a good partner in mix and somebody who's just as dedicated to the process as you are, it makes it very, very easy. So we're planning the implant system that we're going to use. We're planning out every single implant position relative to her bone, hugging the anterior wall of the sinus, changing some positions, moving them palatally, and then planning out our multi-unit abutment. So and then always asking ourselves, remember, who's our patient? So Elaine has some pretty good bite force, and we're in a maxilla opposing a natural dentition. And so I want a minimum in these situations of 6 implants, and she barely has the room for them. We're gonna go second premolars, canines, and central, and we're gonna do 0-degree multi-unit abutments on the centrals. We're going to do 17-degree multi-unit abutments in the premolars and 30-degree multi-unit abutments in the second premolars. So 0, 17 in the canines, and 30 on the second premolars. So here's how everything is going to line up so that we'll have some nice and parallel multi-units. And then you'll also notice, because she's partially edentulous, and remember, our pins are always going to go in the anterior because to hold our bone foundation guide in, but her teeth are in the way. So our plan the day of surgery is going to be to do a serial extraction where we're going to extract 2 teeth, the lateral incisors, and then our third pin is going to go in at the midline, being careful not to hit the incisive canal. And so the depth will be controlled by these green sleeves, and everything is planned out in the software in our VIP call. So here's the implant position. There's our 3 pins. And then I will have Implant Concierge print out her models for me. So the whole maxilla and even the mid face there, you can kind of see. And so if you're new to the system and you want to get comfortable on the bench top, they'll send you your patient printed, which you just saw there. And then you'll notice that everything is labeled for us. So this has a number 1 on it. And this is going to be our seating guide over her teeth. Here's the intaglio that's going to match up with her teeth just perfectly. And then number 2 goes on number 1. So everything goes in order. And so this is how we will get the bone foundation guide here into place. So our order of operations will be extract teeth 7, 10, flap everything, seat the guide. We drill 1, we pin 1. So we don't want to drill 1. We don't want to go through and drill all 3, because if it shifts even slightly, it's going to put a lot of tension on our pins. So I'll drill the midline, I'll pin it. I'll drill the upper left, pin it, drill the upper right, pin it. And then the model that they've printed for us has the ability to detach to simulate the extractions. And then you can go through the system of the multi-purpose guide and then the osteotomy guide you see there, right? Now, to get to the day of, we call this game day around here. On game day, the most important thing is that you get your fiducial markers in before you take any teeth out, all right? So we need to start with 3 scans, and I'm going to show you. So I'm going to anesthetize her. I'm going to anesthetize the palate, and I'm going to put in 2 arch tracers from Digital Arches right in her palate. These things are amazing. I'm going to show you the video merging in just a minute, but they scan beautifully because they've been blasted, so they're dull. There's a little pilot drill, one pilot drill. I'll use the handpiece of the implant motor to put them in. You can also hand torque them in, wrench them in, whatever you want. But the fiducial markers have to go in before you take any teeth out. And then we're going to do 3 scans. We're going to do an upper arch scan with those markers in, a mandibular arch scan, and then I'm going to put in the bite jig that I told you we were going to come back with to get the occlusion. Okay, now let me stress home the point with this slide. If you're going to screenshot anything, screenshot this slide. So let me show you this whole morphing and correlating idea and why we need to use these fiduciary markers. So we have Elaine's initial tooth position. We use that as a reference point to design her final tooth position. I've already kind of showed you that. Now, the fiducial marker is what will relate her soft tissue in her mouth to her existing tooth position. So this is designed based on current tooth position. This will be relative to this position, but if we have this position relative to this, we can then know the fiducial marker relative to her final tooth position. If we just extract all of her teeth and we don't use markers, we don't know where this final design goes in her face. We need to have a way of cross-referencing things, and I'll show you that in a minute. So here's our pre-surgical plan in the software. We scan her mandibular arch. I promise you I'm gonna get that calculus taken care of. We just did, by the way. She builds up incredibly fast. And now here's her maxillary scan. So mandibular scan, maxillary scan with the fiducial markers in, and then the bite relation the jig that I told you with the new vertical in to scan the bite. So that's game day scans, okay? Now, I'm gonna show you a very quick video of the surgery. There's those scans happening in the op. There's the jig I told you about, scanning in the occlusion. Now, lateral incisors removed. Flap the facial. Now, the other thing that we have to discuss is, remember, she's got a lot of infection. She's got periapical lesion, and she has a lot of granulation tissue. So what I like to do in these cases, if we weren't doing guided surgery, what you and I would do is we would take all the teeth out, curette out all the granulation tissue, clean it all up, start placing our implant. I can't take the teeth out. I need the teeth to get the guide set. Once the guide set, it's hard to clean out the soft tissue. Now you'll see I'm just doing a little bit of plastic. So my plan is I get the bone foundation guide set. I'm just suturing up that palatal tissue to get it out of our way. And then these little blue pins, you'll see we have dovetails. Everything just dovetails in. And then I put a little blue pin in to hold the dovetails together. So I don't have to worry that anything is separating at any point during the surgery. Then I'll come through and I'll drill the first drill on all 6 implants. So that I'm not spending a lot of time changing drills. Then I'll come back, second drill, third drill. Maybe a couple of the implants have a 4th drill, and then maybe even some of them have a 5th. But I'll have a flight plan. I'll have my whole plan taped to the wall that I can reference at any point. So all the osteotomies are drilled. No implants have been placed. And then you'll see that I'm even going to remove the bone foundation guide so that I can clearly see and curette out every socket and get all the granulation tissue cleaned up. And then I'll come back through and torque all the implants out. And in her case, a lot of times I'll use a bone reduction guide where I'll flatten everything out if I'm going into an edentulous ridge. In her case, I placed all the implants and I came in and I freehanded the alveoloplasty. Now I'm putting in multi-units, and you'll notice I have these indicator pins on the multi-unit. And remember, the day of surgery, I need to come in and time the implant a little bit differently, possibly. I'm gonna turn the music down just a little bit. Time the implant a little bit differently. It's a change that has to be made on this day. So I put all the multi-units in, I check them, and then I need to come in and turn the implant a little bit more, put it back in, and get them as perfectly parallel as I possibly can. So all of that is done. I do my little papilla haircut, clean the papilla up a little bit on the palate. I don't want a bunch of fingers when I suture things together. I want a beautiful, nice incision line. And then I'll close her up. And then we'll start the magic with the IPGs, the intraoral photogrammetry. I want you to see that here. I'm using 4.0 on an FS2 needle to close her up. PTFE suture, I use it exclusively today. It's the only thing I use. You want a nice watertight seal. And remember, we flapped, we plastied, and so we're gonna have no problem with tension-free, beautiful primary closure. Okay, so here come the RPGs. And so the key to this is we want to be able to capture as many as we can in one shot right there, but we don't want any of them touching. It's okay if they overlap, but they cannot touch. Now we're going to come in with our scan caps. Now, the scan flags that I showed you a few minutes ago are to relate implant position. Okay, so let me show you a few photos of the surgery. Here she is having 7 and 10 removed. The laterals are out. Here's number 1, our seating guide on the teeth, dovetailed in. Right here are the dovetails. And you can see that they print these white lines. If the white line all lined up, I know that it's perfectly seated, and then I pin it. Here's our osteotomy guide in place. Here's our implants. And here's our straights in the anterior, 17 degrees here, 30 degrees here. Here's an occlusal view. Here's the IPGs. So all these names, HACS, scan flags, are all referring to right here. And watch this as we scan it. It only registers the dots, and only thing that we're doing is it's an implant placement identifier. Okay, that's it. Then we come in with the scan caps, and that aligns her new soft tissue position to the implant position. And you scan over them and the software dings. And when it dings, I know it's registered it. And they turn blue when they're registered. So the software is helping you along. And you only need 3. We used 4, even though we had 6 implants. Now watch this. Here's the fiduciary marker. Watch. This is in real time screenshot. And that fast, we've now overlaid and merged all the files, implant position, soft tissue, and now we can relate that back to our initial design. I took 1 additional scan of just soft tissue just for the lab. We don't necessarily have to. We did, and we click right here and add a scan. You can add up to 10. Her whole case, the entire scanning of this case took less than 5 minutes. Actually, 5:48. I think it was less than 6 minutes. And here's merging everything, final check. There's the occlusion that I mentioned to you. So we have the occlusion, we have the opposing, we have the implant position, we have the soft tissue relative to implant position. We got everything ready to go. So here's our post-op CBCT. Now we go to the lab. We're going to use this sculpture material from Rodin. We're going to print it out. It's going to print out 1 color. We're going to come in with some Optiglaze and create some gingiva. And then we're going to take this 3D printed prosthetic and go straight to MUA using these screws. So we don't need to put in any housings. We don't need to do anything at all. And what we're looking for is a beautiful, perfect passive fit. So I'll have her back. Here she is 24 hours post. You can see her soft tissue looks great. Here's the prosthetic seated and a nice, perfect passive seat. I'm going to show you a video of this going in. I'm down to 4 minutes and 53 seconds, so I'm going to speed this up for you. And then I want all of the occlusion between the canine and the second thighs. I don't want any occlusion on the molars, and I don't want any occlusion on the anterior too much. I don't want to create a teeter-totter situation. So I come in, I put some material over the screws. I fill everything. Polish her up. And here's Elaine 24 hours post-surgery. So this was immediately after delivering the prosthetic. You'll see a headshot here in a second. You'll see she's pretty bruised. She's also very swollen, and she still doesn't have very much lip mobility. And so my plan for Elaine is let everything calm down, evaluate things, see if we need to lengthen the teeth, open the vertical more. If you look here at her before photo, and you look at her inner lip distance, you can see it's considerably more than we have here. And so I want her to show more teeth. It was part of my plan from the get-go. And if that doesn't happen when the swelling goes down, I will lengthen things and open her vertical even more. Okay? So there's our cases. I see that I have just a few minutes left here. There's Mila, Jeff, and Elaine. We did composite, we did porcelain, and we did an implant case with the full flow and their final results. And I want to thank you all so much. I'm going to open our Q&A box. I'm going to answer as many questions as I can for you. And moving forward, if you want, now I want you to know that I know that I went through those cases extremely fast. We could probably spend a whole day on just Elaine and implant position and all that planning and the merging of the files and all your questions for photogrammetry intraorally. If you want to get together courses and when we have more time, you can send me a message directly on Instagram, and I will get in touch with you. I'm going to open the Q&A. Do I worry? First question, do I worry about active bruxism damaging veneers? Yes and no. If they brux, they're going to brux. I know that the veneers is not going to change that. So what I'm always trying to do is I'm always trying to build an occlusion that's going to withstand what they're going to continue to do to their teeth. What lubrication did you use on the printed model? I have a number of them in the lab. I think on hers, I used a model separator. What is your favorite for a CBCT? It's an iCat, and my favorite software is In Vivo Mac, which is Anatomage for a Mac, to take that even further. No PRF. Nope, I didn't do any PRF. I don't think it's needed. Not a question, but awesome work. Thank you so much. On the implant cases, how do you manage to keep the patient out of occlusion? We designed it out of occlusion. Now she's going to be in occlusion, but she's only going to be in occlusion where we've designed it to be. And so I only want her hitting on the premolars and maybe on the distal of the canine. And so we've designed it that way. So when we did the digital design, we designed it so she's slightly out in the anterior, and then so she's not hitting anything distal to the implants at all. So we've designed the occlusion where she's hitting, and then she's on a soft diet for several months. A patient will always say, well, what's a soft diet? And we usually tell them anything that they can cut with a fork. Okay, so for the first couple weeks, we want them on a very soft diet. So soups and yogurts and jellos and mashed potatoes and things like that. Okay. And let me see if I have any other questions. I think that is everything. and we are straight up 5 o'clock here right now. So everyone, thank you so much. I hope to see you soon. Thank you, Edwin, and hope everything is well in Spain. I know it's probably 1 in the morning there right now. All right, everyone, have a great night.